All right, good evening. This is Charlie Staley down in Atlanta, Georgia, and tonight I was going to just go through some brief information on cytoreductive surgery and HIPEC. We abbreviate it, which stands for hyperthermic intraperitoneal chemotherapy for peritoneal malignancies. Trying to get the slides to advance.
Try the arrow on the bottom on your computer screen or on your keyboard.
Yeah, I'm doing that now. All of a sudden it's not working, Glenn. It was working before.
We're going to pause the recording here. Okay.
Great, so thank you for your patience. But what we're going to talk about tonight is basically the treatment of peritoneal malignancies. And in front of you is a list of about 5 of the most common tumors that we eventually see in some form as a peritoneal tumor. For many years, cytoreductive surgery and hyperthermic intraperitoneal chemotherapy was really used for a rare group of tumors, the peritoneal mesotheliomas and appendiceal tumors. And we'll talk about now some new data showing its benefit in colorectal cancer, which has really been something that has added to the popularity of this current treatment. But as we look at this list, obviously peritoneal mesothelioma is defined as tumors involving the peritoneal cavity, and so it obviously 100% of those tumors will spread to the peritoneal cavity. Appendiceal cancers will also form either a gelatinous coat of tumor called pseudomyxoma, or will actually attach solid tumors to the peritoneum, and thus we see a lot of these patients for this type of treatment. The gynecologists are also using this treatment for ovarian cancer. I will not really cover that much tonight, but colorectal cancer, with an incidence of 130,000 cases a year, about 10% of patients with colorectal cancer, for unknown reasons, something that we're looking at, and it's a hot topic for research, will, instead of spreading distantly to the liver or the lungs, will spread solely to the peritoneal cavity, and is again another way that we can rid these patients of this disease. So these are some of the cancers that we very commonly use for cytoreductive surgery and intraperitoneal chemotherapy, and we'll sort of go through this individually. This is sort of a cross-sectional anatomy picture, and the blue lines represent what we all have inside us, and it represents the peritoneum. So as you can see, the peritoneum is a sac that covers our abdominal cavity and also covers all our organs, the liver at the top, the transverse colon, which is kind of in the middle there with the squiggly lines, and the pancreas, which is in the back there, that has a peritoneum over the top of it. So many of these tumors can spread to this lining, and this lining is something that we can remove in patients, and it is not very adherent to the tissue underneath it. And it also doesn't tend to penetrate through the peritoneum. So the peritoneum is a great barrier for tumors not to go elsewhere. So we consider the peritoneum basically as a resectable organ, just like you would a piece of the small intestine or the colon. And so one way, an optimistic way that we look at this is not necessarily an unresectable organ and can be removed carefully to get all the disease out of someone with a peritoneal malignancy. And the goal then of cytoreductive surgery is to remove all this disease that we can visibly see in the abdominal cavity. This is sort of a gross picture of what we deal with as abdominal surgeons. This is a picture of what's called the fatty mesentery, which is something we all have that lies over our intestines inside. Some of us have a thicker omentum, some of us have just a little sheer, thin piece of omentum. But what happens is in peritoneal malignancies, like colon, appendiceal, and mesothelioma, these tumors tend to just dot and sit right on this fatty tissue and form a very thick rind of tumor. And so what are we looking for with patients with these sort of problems? Well, we're looking for patients who have, by CT scan or MRI, disease confined to the peritoneal surface. We are not people who have distant metastases. They have colon cancer that has spread to multiple sites in the lungs and the liver and the bone. Those people are unlikely to benefit from cytoreduction and this intraperitoneal chemotherapy. The other thing that's very important is patients who are being considered for this procedure need to be healthy enough to withstand about a 6 to 12 hour operation. And as you'll see from some of the data I'll show in a little bit, how well people do after this surgery is directly related to the patient's performance status. As far as preoperative studies, we usually get a colonoscopy on all the patients and either a contrast CT or MRI of the chest, abdomen, and pelvis. PET scans, to be honest with you, really are not helpful unless there's an area outside of the abdominal cavity or inside the liver that is suspicious and you're trying to decide whether or not this patient has diffuse cancer outside of the peritoneal cavity. Preoperative chemotherapy is something that's still looked at in this disease in colon cancer. A lot of our patients will get systemic chemotherapy as far as a really multidisciplinary program. Preoperative chemotherapy is a bad prognostic factor for patients with appendiceal cancer, and so it really depends on what the tumor is and what you're trying to accomplish as far as how we think about whether or not we're going to give patients chemotherapy before an operation. Just to go through some of the details of the cytoreductive surgery, when we find a patient, again, with either mesothelioma, appendiceal, colon, ovarian, and some of the other rarer tumors, but tumors that are clearly confined to the peritoneal cavity, and we're then going to go and do the operation. We counsel them very, very carefully on the magnitude of the operation and all the things that we can do. I tell my patients that basically this is like anywhere from 3 to 7 separate operations built in one. But pre-op counseling, we usually get them to see our pain service. The incision is usually from just below your chest cavity down to your pubic bone, right along the midpoint of the abdomen. And we usually will get the pain service to put epidural catheters in for pain control. And then we carefully explore the abdomen. And as we said, as I put on this slide, it may require removing a portion of the small intestine, large intestine, omentum, potentially the spleen, the distal part of the pancreas, and then we have to strip all the peritoneum that has this rind of tumor in it. And the completeness of how we remove all this tumor is really the key to the success of this operation. And the goal is to remove all of the visible cancer that you see. This is just a schematic. If you can see, the clamps are on the actual peritoneum, the lining of the abdominal cavity. And what we're doing is stripping that peritoneum off the abdominal wall, and you can see the underlying abdominal muscles. And so we're using that peritoneum as a barrier to remove the tumor that is lining the peritoneum. And we basically do that throughout the abdominal cavity where we see the tumor. We don't routinely strip all the peritoneum off of your entire abdomen if some of it looks normal. So once we have everything removed grossly, we then hook up our cannulas. As you can see, there are 2 inflow cannulas and 2 outflow cannulas that go into the abdomen. We actually then suture the abdominal cavity closed, and then we heat and circulate a couple liters of hot fluid at about 43 degrees centigrade, which is about 107 degrees Fahrenheit. And we then get the abdominal cavity circulating with this fluid. And when we get up to our target temperature, we then add the chemotherapy, which then starts in the circulation in the circuit. And we do this for 90 minutes with the abdomen closed. And when we're done, we passively remove the chemotherapy from the abdominal cavity and open up the abdomen. This is just a picture of what this in real time looks like. You can see the 2 cannulas coming out, one at one end, one at the other. And these are temperature probes that are coming out of the abdominal cavity that allow us to monitor this through the entire process to make sure we're getting the quality temperature of the hyperthermia that we're needing for the treatment. Now the question is so once this is done, we've done our perfusion. What we'll then do is reopen the abdominal cavity. If there are any pieces of intestine we've had to remove, we'll do all our bowel anastomosis, which is hooking all the bowel back up in continuity. Many times we'll put a tube in the stomach because the stomach is not going to empty well, so patients won't have to have an NG tube or a tube in their nose to decompress their stomach. Sometimes we'll use a feeding tube. The other tubes that potentially we'll use are chest tubes. If we've stripped the peritoneum off of the diaphragms, they'll usually be what we call an effusion of fluid into the chest cavities, and so by putting these tubes in, patients just breathe easier after the operation. It's about a 6 to 12 hour operation. Patients usually remain ventilated overnight and remain in the ICU for 1 to 2 days. The median hospital stay, which is an average, is usually about 10 days, and it truly depends on what is the extent of the surgical resection that we had to do as far as how long people need to stay in the hospital. Now, the rationale for the temperature is manyfold. The temperature is the heated temperature makes the chemotherapy work better. So it's the synergy of the temperature with the chemotherapy that allows the chemotherapy to kill more cells. The chemotherapy itself can directly infuse into small tumors that are 1, 2, and 3 millimeters. So we actually could potentially leave a couple millimeter tumors behind, and the chemotherapy would kill those tumors. Beyond that, they really can't directly penetrate into tumors bigger than that. But the nice thing is that there's sort of a barrier in the abdomen to allowing this chemotherapy to get out. So we can get a much higher concentration of chemotherapy in the intra-abdominal cavity with this type of treatment, perfusing the chemotherapy directly into the abdominal cavity. When we're done with the operation, we actually score everyone's disease, called a PCI, or a staging system. As you can see, we split the abdominal cavity up into 9 regions and basically score it by the size of the tumors in each of these regions. And so this is basically a way for us to score the extent of someone's disease and compare the results. Now, the nice thing about this operation is that we've been doing this operation for 20 and 30 years. So there's actually a very good experience in doing this type of therapy. The mortality, the chance that you could die of this surgery, is really the same as any major resection of the pancreas, liver, or any other major abdominal operation. It's about chances of dying are anywhere from 0 to 4%. But we cannot state that there are complications of this operation. They are manageable, but about 40% of patients will have some type of complication. As you can see by this pie graph, certainly there's a risk of bleeding, bowel perforation, which is a hole in the bowel, respiratory problems, pneumonias, infections, and then leakage from places where the bowel had to be sewn to. The vast majority of these complications are very manageable. Very few people need reoperation for any of these complications, but it's certainly a long road to recovery. This is just some examples of how patients are doing after this surgery. On the left, you'll see a graph basically showing some of the best survivors are appendiceal tumors, followed by ovarian, mesothelioma, and really the worst group that just doesn't seem to benefit this right now are those with gastric cancer. But I will say there's some new interesting data coming from our Asian colleagues that may call this into question. But overall, as you can see by the graph on the right, about a third of the patients with tremendous metastatic disease, if they get good cytoreduction and intraperitoneal chemo, can live, about a third will live long term, and that's at 10 years.
All right, I'll just listen on this.
Factors influencing survival are two major things that I talked on before: patient performance and the completeness of the cytoreduction. So if you have a good patient performance and are not sickly and malnourished, and we can surgically go in and remove all the disease, that is the best scenario that we have at getting patients to live long term. And just to go through some of the categories that we deal with, peritoneal mesothelioma certainly is much rarer than the more lung-based mesothelioma that you hear about that is so attached to asbestosis exposure. Patients usually present with abdominal pain, fluid in the abdomen. To this date, there's no intravenous chemotherapy that is effective, and survival is usually less than 12 months. But and this is just a CT scan that you can see all the hazy fluid, this whitish sort of light-colored fluid around all the abdominal contents is all the ascites that is associated with mesothelioma. But if you look at some of the results, and these are in over 400 patients, the long-term survival is just over 50% for a disease that I just said to you, untreated, has a survival of less than 12 months. So I generally tell patients with this type of treatment for this disease, we can extend their lives and potentially cure them 5 to 6-fold compared to no treatment or systemic chemotherapy. This is a CT scan of appendiceal cancer or pseudomyxoma. We casually call these sort of jelly bellies. There's a tremendous amount of mucinous jelly within the abdomen that is being produced by these appendiceal tumors. These tend to be slow-growing tumors. They come in two forms, but the overall survival, as you can see by this graph in the blue line, is about 75% long-term survival with cytoreductive surgery and HIPEC for these type of tumors. There are two different histologies, and on the graph on the right, the blue line represents the low-grade tumor, and the green line, the PMCA, is a more aggressive histology of appendiceal cancer, and obviously they don't do as well from a survival standpoint. So if you have appendiceal cancer, it's very important to have your pathology looked at by somebody who's used to looking at this type of cancer to get you classified into the right pathological subtype. Basically, when we look at colon cancer, overall, the median survival, if we can resect liver and lung metastases, patients can have a long-term survival. It had been thought years ago that once someone had peritoneal disease from colon cancer, really the options were very limited, and palliative chemotherapy could extend their life maybe in several months. But with a little bit better thinking, there was a group from Australia that compared curative resections of liver tumors from colon cancer to a cytoreductive surgery, and found out that basically patients were living long-term by removing their peritoneal tumors, and in fact living just as long as an accepted treatment of removing a portion of their liver. And so this has really sort of validated what we all seem to think, that if you can get aggressive with peritoneal carcinomatosis from colon cancer, these patients will do just as well as other potentially curative surgery. This is an example of really the landmark trial that was done in the Netherlands in the late 90s. And what they did was they took patients with colon cancer with peritoneal disease and randomized them to either getting systemic intravenous chemotherapy or a program of cytoreductive surgery, HIPEC chemotherapy, followed by systemic chemotherapy. So really what it was testing was, what is the role of cytoreductive surgery plus HIPEC in making a difference in these patients? And as you can tell, the mortality was 5%. It was a little higher than what you'd want to see, but certainly in the ballpark. And then when you look at the results, there was a doubling of survival with patients that had the HIPEC in addition to the systemic chemotherapy. And so, you know, this is what has really swung the barometer and has brought many of the societies to validate this type of treatment for peritoneal disease from colon cancer, and has also, very frankly, helped us with insurance companies help get this approved for patients with colon cancer. Even more recent data from our colleagues in Europe, looking again at systemic chemotherapy versus cytoreductive surgery and systemic chemotherapy. And as you can see by the blue line, there was a significant benefit of those patients who had the cytoreductive surgery and HIPEC compared to chemotherapy alone. And in fact, the median survival of patients undergoing HIPEC is 62 months, which is unheard of for somebody with metastatic colon cancer. Just one last couple slides. One basically on quality of life. I think as surgeons, we can't be too enamored with our surgical work, and we have to very carefully look at how patients get over this operation. It is a big operation. It really takes months to get over this operation to really get back to baseline. But when patients go home, again, they're eating, getting around, walking around on their own, and slowly starting to do exercise. But I tell patients it's basically going to take you a good 3 to 4 months to feel like you're getting back to totally normal life. So in summary, the sort of strategy, an aggressive strategy of cytoreductive surgery and HIPEC is safe. If it's done in high-volume centers, there are clearly centers around the United States that have these programs. I started doing this about 25 years ago when I was a fellow at MD Anderson in Houston, and then have been doing it here at Emory University. We've shown that there is a benefit of this treatment in the specific tumors we talked about. Patient selection is very important. Surgical technique is very important. Here at Emory, we have a complete team that does this. There are only certain anesthesiologists, certain nurses, and certain nurses in the ICU and the floor that take care of these patients, because it is a very specific group of folks that have trained very long and hard to deal with these sort of patients. So I've shown you some data on mesothelioma. I think that is the rarest tumor but has the greatest benefit from this therapy. I think appendix cancer is the next, and it really is dependent a little bit on the type of histology that you have. And systemic chemotherapy really has not been helpful for this disease. And then when we look at colon, there's increasing evidence that this sort of strategy works for patients with colon cancer. As I said, about 10% of patients will have disease only confined to the peritoneal cavity, and this, along with systemic chemotherapy, I think is really going to help patients with this type of problem. The one little caveat I would say is there is a growing histology of signet ring pathology in colon cancer that is a more aggressive therapy. A lot of us feel that this disease is probably better treated with chemotherapy, but I will say to you that patients with low PCI scores and minimal disease, we have had a pretty good result of getting them cytoreduced. So future directions, we really need more clinical trials nationally. We need to look at standardizing the chemo drugs that we use a little bit better. The folks in Korea and Japan have brought some new data on gastric, which may get us a little bit more invigorated about this disease. And I think one of the key things that we go around the country really trying to talk to our medical oncology colleagues is that we really want to try to see these patients early when there's less bulk of disease. I think there's a very direct correlation to the amount of disease and the ability of the surgeons to totally go in and do a complete cytoreduction. If you wait, say, with someone with colon cancer who's now on their 4th line of treatment and their entire abdomen's full of solid tumor, trying to do a complete cytoreduction is going to be extremely difficult. So I hope I've given you a little bit of information on this procedure and who we do it on and what the results are. I'd be happy to answer anyone's questions.